Hi, and welcome to our Unit 4, where we are going to continue with our cardiac content that we started in Unit 3. So, uh, this is a reminder that you should review the slides on EKG reading and rhythm reading from the EKG lab that we had. And then just a little bit of a review, which I went very quickly through with lab, is the blood flow of the heart and the structure of the heart. So the heart itself is composed of muscle, specialized muscle that can also conduct electrical charges. And it all serves to work as a pump to provide oxygenation and blood flow to the body's organs and tissues. We have four main chambers. We've got the right and left atria, the right and left ventricles. We've got some different valves. We've got on the right side the tricuspid and the pulmonic. On the left side, we've got the mitral and aortic. When we auscultate the heart, we hear the lub-dub. The lub is also called S1, and that is the ventricles squeezing during systole, and the tricuspid and mitral valves close. Then we've got the dub, which is the S2. That's when the ventricles relax, the atria fill with diastole, and the pulmonic and aortic valves close. So everything should work together in coordination, and the left and right valve pairs should open and close simultaneously. The left ventricle is the most important pumping section, and it's usually bigger and stronger than the right ventricle. Remember that the electrical conduction is what is driving the pumping coordination, and that electrical conduction is why we can use an EKG strip to visualize the conduction of the impulses through by time and amplitude. So time moving left to right, amplitude up and down. And that's why our QRS complex is so much bigger than our P wave. Okay, and then the other side of that, and it showed on the previous slide, the blue side of the heart is the side that has unoxygenated blood. The red side is the oxygenated. So just a reminder to know that blood flow pattern, because when there are right-sided pumping problems, it backs up to the body and can have an inadequate supply to the lungs. With left-sided pumping problems, it can back up to the lungs, and if it's really bad, right on through to the right side of the heart, and there can be an inadequate supply to the body pumping out. So that plays a role in heart failure. This is a reminder of those key electrical sites that we talk about when we are watching the electrical conduction of the heart. The big ones to know is the SA node. That's what kicks it all off. Then it travels down to the AV node, and then it kind of hangs out at that bundle of His for a little second, and then it goes down the right and left bundle branches all the way through the Purkinje fibers. And that is one heartbeat. That happens over and over and over. And that is contingent upon there being adequate blood flow to the heart muscle so that it can do its function, which is pumping. And so I've mentioned this before. The perfusion is with the coronary arteries. That's what is the blood flow to the muscle. And if there is occlusion in one of those coronary arteries, that's what triggers a heart attack. And we can see that on an EKG depending on what side of the heart we're looking at and what side of the heart the occlusion is on. And the big thing I want to show you with this picture is the higher up the occlusion is, the larger the blood flow blockage is. So it's going to have a larger effect over a surface area. So the higher up the damage, the more severe the damage it is because it supplies more blood to the heart. That's the big thing to take away from this. And so this picture shows us that electrical pathway through the heart, and then what do we see on the EKG strip? So it is dependent on healthy cells, good blood flow, and electrolyte balance. So our sodium and potassium, etc., etc. The sympathetic nervous system and parasympathetic nervous systems are both embedded in the cardiac system as well. Remember that the sympathetic nervous system is the gas pedal. Give it more gas, go faster, increase that heart rate, increase that conduction speed, give it more forceful contractions. Then we've got the parasympathetic nervous system. That's our brake. Whoa, let's slow things down. That's going to slow the heart rate, slow the conduction, and decrease the force of contraction. And when we talk about different medications, like our beta blockers and our calcium channel blockers, they are affecting that sympathetic nervous system. And so if we look at the pathway of conduction and the EKG, we see this correlation. So the P wave represents atrial depolarization. So the electrical conduction going through that right atrium. The PR segment represents impulses traveling through to the AV node. The PR interval is the time required for atrial depolarization, as well as the impulse and that AV node, the bundle of His, and travel time for the Purkinje fibers. Okay? Then we've got the QRS. The QRS represents the time required for depolarization of both ventricles. And then lastly, the T wave represents ventricular repolarization. You can have other wave issues, other waveforms, but these are the key things that you want to have committed to memory and understand. Let's see. We should have a P wave for every QRS. So that represents depolarizations from both the atria, which is the P wave, and the ventricles, which is the QRS. The PRI, or the P to R interval, should be 0.12 to 0.20. That's a normal range. And the QRS range should be 0.04 to 0.10. You should know these values and know that it represents how much time it takes for the electrical conduction to occur. So upwards to this point, that all should have been review from what I talked with you about in lab. From here, we are going to go into some new information and a repeat of some of the other information as well. So with this one, in a nutshell, this is normal sinus rhythm. We've got P, QRST, P, QRST. We have one P wave for every QRS. Each P wave looks alike. We have T waves. Our heart rate is 60 to 100. We have a very regular rhythm. We have, if we did our measurements, we would have a PRI, PR interval of 0.12 to 0.20, and our QRS is less than 0.12. So that is what normal sinus rhythm looks like. Then we've got sinus bradycardia. So it's got everything that it's supposed to have. We've got a P wave, a QRS, a T. The P waves, there's one to every QRS. Our PRI is normal. Our QRS is normal. The only thing that's different is it's going too slow. It's going less than 60 beats per minute. So, sinus bradycardia is when the heart rate is less than 60, and we should always assess our patients because this actually could be normal if they are highly athletic. It could also be not normal. It could be a medication side effect. It could be an electrical conduction problem in the heart. With anybody that has a heart rate less than 60, you want to instruct them not to bear down while having a bowel movement because that stimulates the vagal nerve and could further drop their heart rate, causing them to pass out. If a patient has sinus bradycardia and they are hypotensive, you will need to treat. And the treatment that we will do is typically atropine or epi, but it has to be with symptoms. So low blood pressure, bradycardia with symptoms. Okay, from here, just to hit it home, if your patient's hypotensive, if they've got a slow heart rate, they could become dizzy and faint. And if that happens, we want to administer medicines that are going to increase that heart rate and then increase the blood flow. And that's why we give atropine or epinephrine. So from there, we go to sinus tachycardia. So this is a normal looking EKG. It's just too fast. We have a P wave, a QRS, a T wave, but it's greater than 100 beats per minute. And usually this is not anything to worry about unless it happens over a period of time. There are some very common things that can cause sinus tachycardia, and they include caffeine, nicotine, alcohol, and drugs. Patients can report feeling heart palpitations or like a fluttering in their chest. If your patient has tachycardia and chest pain, this calls for immediate medical attention, and we're going to slow that heart rate down. From there, let's talk about atrial arrhythmias. The two big ones is AFib and A-flutter. The big way to tell them apart is atrial fibrillation has chaotic P waves. They're not true P waves, but where the P wave is supposed to be, it's just a series of chaotic bumpies. Atrial flutter has sawtooth patterns. Okay, so it is a predictable pattern between the QRSs. Okay, with either AFib or A-flutter, some common signs and symptoms are shortness of breath and anxiety. With AFib in particular, there's a high risk for stroke, so we want to monitor these patients for neurological changes such as slurred speech. And then to prevent clots, anybody who's on atrial fibrillation, think, are they on Coumadin? Are they on warfarin? And we're going to talk about those a little more detailed. So the first one I want to talk is atrial flutter. It is regularly irregular, which means there's usually a pattern, and we have that sawtooth appearance P wave. The atrial rate is usually much faster than the ventricular rate. We can't do a PRI measurement. There are no true P waves. So this picture is an example of atrial flutter. And like I mentioned, common symptoms they can complain of is shortness of breath. They can also report dizziness, lightheadedness, palpitations, or feeling like they have an irregular heart rate. However, some people will have no symptoms at all, and it's not clear why some people have symptoms and others do not. From there, we've got atrial fibrillation, and just think fibrillation chaos. There's no nice pattern here. There's no P waves. They're just erratic waveforms. There's irregular distances between complexes. And what is happening is the heart atrium are quivering and they're not effectively pumping. The impulse to generate a heartbeat is supposed to come from the SA node. With atrial fibrillation, it's coming from an ectopic focus, an area that is irritated and shouldn't be conducting an impulse is. So the problem is that when atriums quiver, they're not pumping effectively, and blood has a chance to develop a clot, and that clot could then travel through the heart all the way to the brain and cause a stroke. So, in order to reduce this risk, we need to take some precautions, and most commonly, it's going to be an anticoagulant. Warfarin is a very common anticoagulant used, and it helps decrease the risk of clots. And the lab value we need to assess when a patient is on Coumadin or warfarin is your PT-INR. And generally, the goal, a normal INR is around 1. If a patient is on Coumadin for atrial fibrillation, the goal is usually for it to be 2 to 3. Um, Sometimes, in addition to anticoagulation, we have to give them medicine to help control their heart rate because it wants to go too fast. And a common medication prescribed for heart failure is digoxin. Um, and these patients are also at risk for developing heart failure. Um, and heart failure is more likely to occur when people in atrial fib, their heart rates are faster than normal for a long period of time. And so that's why we want to control not only the risk for clot, but slow that rate down. Okay? So let's recap. Atrial fibrillation. What is it? It is uncoordinated firing of electrical impulses in the atria from an ectopic focus that causes quivering, ineffective contraction of the heart, pooling of the blood, and increases the risk of clots forming. And because of this quivering and ineffective heart contractions, it is potentially going to cause ineffective cardiac output and perfusion. It's usually rapid unless a patient is taking medications to slow it down. That's the most common presentation. It's not life-threatening alone, but it can cause blood clots and then strokes. What causes AFib? Well, structural abnormalities, hyperthyroidism, and it seems like people as they get older, they can develop this. What are the signs and symptoms of atrial fibrillation? They can be asymptomatic. They can have an irregular pulse. They can feel faint. They can have heart palpitations, report feeling lightheaded, or have shortness of breath. What do we need to monitor? We need to monitor for signs and symptoms of decreased blood flow, poor perfusion, altered mental status, slurred speech, and other stroke signs and symptoms like ataxia or a facial droop, the cool extremities, and an increased heart rate at rest. What's the EKG going to show? It's going to show chaotic, low voltage waves where the P wave is supposed to be. The QRSs are going to be irregularly spaced apart. What is our treatment? The goal is to try and restore a regular heart rate and rhythm and prevent clotting. So if they're in atrial fibrillation for less than 72 hours, we will try to do a cardioversion. So we'll give them a sedative and we'll shock their heart, trying to get it reset. If it's been greater than 72 hours, we have to think anticoagulation. Because once it's been going on for more than 72 hours, there's the risk that they already have a clot in there and it could travel through. So we're going to give them anticoagulation. If it is stable atrial fibrillation, we're going to use antiarrhythmics like amiodarone or cardizem. If it's unstable atrial fibrillation, we're going to do cardioversion or a pacemaker. We are going to educate these patients to avoid caffeine, nicotine, and alcohol. We're going to educate them on Coumadin, that they are going to have frequent lab tests, specifically the INR. Diet, they don't want to eat food, a lot of food high in vitamin K because that's the reversal for warfarin. They shouldn't take any sort of NSAID or aspirin as long as they're taking warfarin. And if they have lightheaded dizziness, spontaneous bleeding, they need to report that to their physician. Okay, so from there, we're going to switch from the atria down to the ventricles. So basically, the first thing I want to talk about is a premature ventricular contraction. And the underlying heart rate is based on what their rhythm is. What happens is the ventricle gets a little bit of an irritated site and it jumps in prematurely before it's supposed to conduct. And so usually PVCs are wide, weird, and upside down, but they can look like what's on the screen as well. I've got another picture here. The circled guys, those are examples of PVCs too. So usually they're wide, weird, upside down. There usually is a little bit of a pause right afterwards, and then the underlying rhythm picks up again. So these are all examples of PVCs, and they can be harmless or there could be an underlying cause. The normal cause for these to happen are caffeine. And so easy treatment, minimize or stop drinking caffeine. Um, Sometimes a heart rate will increase slightly during inspiration and decrease slightly during expiration. Sometimes people throw occasional PVCs while exercising. Occasional ones when this and these heart rate changes are normal and we just document the findings. The thing that we want to watch for is if they are having more and more frequent PVCs, especially if they've had a heart attack. Because if they start getting a bunch of these in a row, they could actually go into ventricular tachycardia, which we're going to talk about next. So ventricular tachycardia is one of those emergency heart rhythms. We need to shock them. All right. These patients may or may not have a pulse. There's no P wave. The rate is going fast. QRSs are going to be hard to manage. And usually if they have a lot of PVCs in a row, for example, 30 seconds worth of PVCs, we consider that to be VTAC. And so let's break it down. What is VTAC? It's abnormal electrical impulses in the ventricles that cause the heart rate to contract too fast. Usually it's around greater than 160 beats per minute. And what this does is it causes inadequate filling of the ventricles between beats and less blood being pumped out. So what are the signs and symptoms that if someone's in VTAC? Well, they could be unconscious. They could stop breathing or be breathing really slowly. They could be pale and sweaty. They could be dizzy related to the decreased oxygen being delivered to the brain. They could have a very low blood pressure, weak pulses, all indicators of inadequate perfusion. What can cause VT? Heart attacks, cardiomyopathy, coronary artery disease, mitral valve prolapse, drugs, and many other things. What's going on with the EKG? It's unusual QRS. There's no P wave. It's going fast, and it can start and stop very suddenly. What tests are we going to do? We're going to do an ABG. We're going to look at a CBC, a CMP, and we're going to perform drug tests. Treatment, if there's no pulse and not breathing, we're going to do CPR until someone that has advanced coronary life support training can take over. Then we're possibly going to trach them, put them on a vent, give them supplemental oxygen, breathe for them. We could give them an antiarrhythmic. Specifically, we could use lidocaine. We can use epinephrine. We can use amiodarone. And anytime you're infusing these antiarrhythmics, you want to watch their vital signs very closely because you may have to titrate the infusion rate if the blood pressure or pulse goes too low. And we could also try and cardiovert them. So just try and give them a shock. and we could do all of the above. So this is a shockable rhythm. Okay. From there, just a reminder for VTAC, it's a rhythm that we always treat the patient, not the monitor. If your patient becomes unresponsive, start CPR. Always assess your airway and the level of consciousness. These patients can turn fast and you need to be on top of it. These patients could be talking to you 1 second and then coding the next. Just a word about amiodarone. It's an antiarrhythmic medication. It is used to help keep the heart beating in people that have life-threatening heart dysrhythmias. It can be used to treat ventricular tachycardia or ventricular fibrillation, which is what we're going to talk about next. So, ventricular fibrillation. Fibrillation, think chaos. We know it's the ventricles because there's no QRS complexes, so the problem has to be in the ventricles. And what is happening with this is the muscle is just quivering. There is no effective pumping going on. So what is VFib? Electrical impulses are firing erratically, making the ventricles contract and quiver, and actually preventing regular effective contractions, and that disrupts blood flow to the body. What causes VFib? VTAC can actually cause VFib. So can electrolyte imbalances, heart attack, getting an electrical shock, drugs, and other conditions too. What are the signs and symptoms? No pulse, no breathing, no blood pressure. The EKG just shows you that chaotic wave. What are we going to do to treat it? We're going to start CPR. We're going to do advanced coronary life support. We're going to give them a shock or defibrillate them, and we're going to correct the underlying problem. We have to identify what is causing this VFib. Okay, and then we've got just a broad category. Supraventricular tachycardia. What that means is it's a tachycardia that originates above the ventricles. And it can be nonspecific. We don't know what it really is going on, but we know the problem's above the ventricles because we have QRSs and the heart rate's going too fast. So these patients, because it's going so fast, the heart doesn't have adequate filling time, so we have a drop in cardiac output. The symptoms that people can experience with SVT is shortness of breath, chest palpitations, chest pain, dizziness, rapid breathing. They can complain of numbness in parts of their bodies, and they can lose consciousness. The pathway of choice for treating SVT is based on whether the patient is stable or unstable. Unstable patients with SVT and a pulse are treated with cardioversion. If your patient is stable with SVT, they may try medical interventions like carotid massage or ditalazam, cardizem. That's a calcium channel blocker that is an antiarrhythmic. And then just to touch base on some coronary procedures. The first one I want to talk about is cardiac catheterizations. We need to watch these patients for bleeding. Post-procedurally. A lot of times we watch the insertion site for bleeding from the site or a hematoma formation. And a hematoma is a collection of blood underneath the skin. And we do that for a couple of different reasons. One, because it's kind of a large puncture to thread that catheter through the blood vessel. And we often give them blood thinners, for example, something called Repro. And we give them blood thinners because it decreases the chance of heart attack if they need an intervention to open up a blocked artery. We also want to do our 6Ps, so our neurovascular assessments, especially on the extremity that we access the site. We're also pre-procedural. We're going to do 2 good peripheral IVs. We're going to start IV fluids. We're going to get our lab values. So lab values that are important to assess are CBC, BMP, BUN, creatinine. We're going to do coagulation studies. We're going to look at cardiac biomarkers like troponin, and we're going to do a urinalysis. We're also going to have the patient get a chest x-ray and an EKG. And another thing post-procedure, which the blood urea and creatinine reminded me, is we use contrast in order to see the blood vessels in a coronary catheterization, and they need to be able to get rid of that contrast, so they need good renal function. So we're going to watch urinary output and those labs afterwards as well. This picture just shows you how that catheter gets inserted in the groin, threaded up through the heart to access the coronary arteries. And this one is the heart blown up to show you how we go from the aorta to the coronary arteries to look at them. And this is an example of an x-ray image, and the arrow is pointing to where there is an occluded coronary blood vessel. That little pinched off area, that's where there's a clot. And there's just enough blood flow that beneath the blood, where the arrow is, there's still flow. So we want to open up that area to make sure there's adequate blood flow. And we can do that with a balloon, or we can do that with a stent, or we can do kind of a rotor rooter to get that plaque out. If your patient has this procedure done, afterwards we're going to do frequent vital signs. We're going to do frequent insertion site assessments. We're going to closely monitor level of consciousness, heart tones, assess for chest pain, and notify the MD if they have any change in level of consciousness, show signs and symptoms of a stroke, if they have chest pain, or if they have diminished pulses anywhere, because little pieces of plaque can break off and occlude other blood vessels. From there, this is an example of an internal cardioverter defibrillator, ICD. So what it does is it detects if the heart rate goes into a dangerous rhythm, and it can shock them to get them back into a normal rhythm. If it has the pacemaker capability, it can actually initiate a heartbeat. So if your patient has some sort of a heart block and they get a pacemaker placed, that is an artificial SA node, essentially, is what they're getting. So an implantable cardioverter defibrillator continuously monitors the heartbeat and delivers extra beats or electrical shocks to keep or restore a normal heart rhythm when necessary. As I mentioned, a pacemaker generates a heartbeat to keep it in that greater than 60 range, and generally you're going to see what we call pacer spikes, and that is right before each P wave there's that line that goes down. That's your pacer spike. We want to always make sure that there's a QRS after the pacer spike, because if there's no QRS, it's called loss of capture, and your patient may not be perfusing, the ventricles may not be pumping. So it should be pacer spike, P wave, QRS, T wave. We still want to watch for that. If they have a pacemaker, they need to be instructed to stay away from strong magnetic fields like MRIs. And then next up and lastly is coronary artery bypass grafts or CABGs. There are several different types of bypass grafts. The surgeon decides what grafts to use based on the location of the blockage, the severity of the blockage, and the size of the patient's coronary arteries. And this one shows you how they get their name. If it's usually they'll say cabbage times 2 or a quadruple or whatever. That means how many different grafts did they place. So if there's one graph, it's a single. If there's 2 graphs, there's a double, etc., etc. And with this, post-operatively, they're going to come back to us with some draining tubes. We always want to check all drainage tubes for kinks to make sure they can drain properly. Post-CABG, we want to be assessing them for heart arrhythmias like atrial fibrillation, any changes in mental status. We will work to gradually increase their activity while we closely monitor blood pressure, pulse, respiratory rate, and oxygen. And if a patient complains of chest pain, we can't advance them any further until they tolerate whatever that activity is with minimal changes in their vital signs and chest pain. So with these patients, we really have to watch them closely and monitor their tolerance and pain levels. All right, that brings us to the end of this recording. Thank you so much for listening, and please let me know if you have any questions.